Hello. Um, my lecture is about evidence-based medicine. It's an overview about the process. So I'm Dr. Nilo Vincent Flor Cruz, um, and I'm going to start the lecture. Okay. Oops. So around 1991, uh, in the field of medicine, this is Dr. Gordon Guyat. He's from Canada, from the University of McMaster. And he's an internist and clinical epidemiologist who then was a residency training officer of the Department of Internal Medicine. And he proposed that residents should start conscientiously identifying, appraising, and using research evidence in their medical decision. Initially, he called it scientific-based medicine. There were lots of objections to this because, especially from the consultants, because they were saying that does it mean that we have not been scientific all these years? So, to be politically correct, he coined the term evidence-based medicine. Okay, so um, more than how many? More than 19 years have passed, and worldwide has become a phenomenon. Its principles being taught, utilized, and practiced in all areas of medicine, being adopted by medical schools, um, medical centers, institutions, and medical organizations. It has become a paradigm shift on how we make or how we reach medical decisions. So this is the outline of my lecture. What is EBM? Why do we need EBM? What are the steps to practice EBM? And how do we start? Okay, so let's start. Initially, this is how we decide on things. No? We have our clinical expertise, our knowledge, our what we learned from medical school. There's the research evidence. These are the published articles, trials from the journals. And of course, there's the patient preferences. Okay. Um, this is how we do it during the early 90s, no? And well, research evidence is the real EBM here, but it's it's not integrated, no? So in truth, these are not mutually exclusive in medical decision making. Therefore, there should not be any conflict, no? You cannot make decisions based on the individual components. So what's the difference, no? Right now, no, so this is early 1990s. So yeah, right now, as physicians, we have to incorporate and integrate the three areas of decision making. As physicians, we need to be experts in identifying all areas. No, the current definition of practice of EBM that this means that expertise, we are experts in integrating the best available research evidence. No, not everything will have evidence, and not all evidence is useful. In the real world, you will not always have the ideal evidence for all your clinical questions, but this should not paralyze you into inaction. Number two, clinical circumstances. Um, Clinical experience and expertise will be essential. No, as you grow old during in your practice, you will see what are the effective treatments that you did, what were the failures. Okay, you cannot use evidence if you do not have right disease in the first place. So yeah, you should have a good clinical eye in order to determine the right or correct diagnosis. And next is the patient values, no? You give importance on what your patient values. Not all should be based on the physician's decision, no? So in medical decision making, Sackett says that without clinical expertise, practice risks becoming tyrannized by evidence, for even excellent external evidence may be inapplicable to or appropriate for an individual patient. Without current best evidence, for practice risks becoming rapidly out of date to the detriment of the patient. Okay, so that's what we need, no? The clinical expertise, the combination of these three factors, no? Okay, next. So here, no, evidence-based medicine is expertise. You're expert in integrating the best research evidence, the patient values, no, how you apply the evidence to the to your patient, and the different circumstances in your clinical decision making. So why do we need, or why do we need EBM? Okay, so well, during the 1990s, there were studies on clinical performance versus time. You can see here on the y-axis are multiple choice question scores from 0 to 80, and the x-axis is the years after graduation, no? So it's the range from 3 to 42 years after graduation. So you can see the line, it's going down here, no? So as you grow old, you get poor in answering those multiple choice questions, no? So we need to update ourselves, or we run the risk of becoming passé, especially at the rate we are becoming bombarded by information, no? In summary, there is a perceived need for EBM and actual need as well. Now let's see. Okay, so here are some clinical questions by internal medicine residents. No, how badly do we need EBM? Okay, let us look at a more systematic study. No, among internal medicine residents, a study showed that they have a lot of information needs. No, they ask 2 questions for every 3 outpatients they see, and 5 for every inpatient. No, however, they only pursued an answer for 29% of these questions, and most questions were answered by books, journals, or asking a colleague. Okay, this demonstrates that the physician needs more for the physician's needs for information. The most common barrier to obtain an answer is lack of time. Okay, so masyadong busy yung resident, and sometimes they forgot. Okay, so next, where do we get our information? No, this is a survey. So reported, no, human source, it's reported to be 33%, but actually it was more than that, no. Mas madali, it's more easier to ask another person, to call a friend, to ask a consultant, no. Printed sources, no, 62% reported against 27% observed. And from the printed sources, it's mainly textbooks, no. Journals is only 18%. And actually, what is observed is just 7% for the journals, no? And 3% for the textbooks. So, mas marami pa from the drug companies. Okay? Next. So, what's the minimum reading to keep up to date, no? So just looking at eight major looking here, no, the available journals in ophthalmology. There's the Ophthalmology Journal. There's British Journal of Ophthalmology. There's the American Journal of Ophthalmology, the IOVS, and others. No, in the Philippines, we have the Philippine Journal of Ophthalmology. So there's a lot of articles being published in these journals, and I don't think we'll be able to read everything. Okay, you need 5 articles per day. Okay, so what are the steps um, in practicing EBM? Okay, so there's a cycle, no, as shown here in the slide. Okay, so first there is you ask for the clinical question. Then, based on your clinical question, you search for the best evidence, no? A systematic search for the best evidence. You go to the PubMed. Then, when you are able to get the articles and the journals, you critically appraise it. Then, eventually, you integrate the data. And then here, there's medical heuristics, wherein simple decision strategies are used, and you ignore part of the available information, and you base your decision only on the relevant predictors. And eventually, you make a decision. So it's a cycle. Okay. So that's the EBM cycle. No, it's not like this, no. You ask a question, then eventually hindi siya random, no? Cause and effect, no? So it's not like this. But yeah, this is an example of our antibiotics, our antibiotic steroids effective in treating uh, viral conjunctivitis. Okay, so ask a question. Okay, then number 2, acquire the evidence. Okay, so you go to the internet, you search for the PubMed, and then you look for the relevant articles. Do you go to the library? Maybe not anymore. There are virtual libraries right now. There's the Sci-Hub where you can get the full text journals of the articles. Okay. Do you do Google? Well, it's not advisable, but of course, it's very easy to Google a question. It's important. This is the ideal way of searching for the evidence, no? You go to PubMed, okay? So like this one, no? You search for the evidence on viral conjunctivitis, and you get a lot of published articles. Okay. You can also search through Google Scholar. There are significant articles wherein they already classified those articles based on the topic. Okay. And there's another one, the Cochrane Library, wherein you can search for the different systematic reviews, or some with meta-analysis. Okay. So just a summary, you can find evidence by using the PubMed through the internet, and another option is Cochrane Library. Okay, so this is an example of a published article in Cochrane, the medical interventions for fungal keratitis. I did this during my residency period. So I did the protocol first, and eventually came out with the published or finished article. It went to a second revision around 5 years ago, because systematic reviews should be updated once in a while, no? Especially if there are new trials that come out, no? So I think this is already due for another update. Okay. So yeah, when once you get those articles, you just don't follow or read the conclusion. What you need is to appraise the evidence, no? Don't just read the abstract or even the conclusion. You need to appraise, is it, I mean, the methodology, okay? And then eventually, you need to apply the results to your patient, okay? So before going applying it to your patient, let's go back to the appraisal of the evidence. So um, for there are ways to appraise the evidence, no? Because especially for the therapeutic trials, no? You have to check if they were able to randomize the patients, no? To allocate them uh, blind, there's allocation concealment, there's the biases, no? Uh, Selection bias, was it avoided, no? The the outcome observers, were they masked, no? So those are the things that you check uh, if uh, the methodology was done properly. Okay. So if the trial was good enough, no, eventually you may apply it to your patient, no, and these are the things that you check, no, if the trial is applicable to your patient, no. So you check for biologic factors that can threaten the applicability, the sex of the patient, of your patient, the comorbids of your patient, the race of your patient, the age of your patient, and the pathology. Um, as a simple guide, uh, you check if your patient qualifies in the inclusion criteria of the article that you've read. No? So kung pumasok siya, if he became an exclusion rather than inclusion, I don't think that article is applicable to your patient. Okay, so eventually you're going to make the decision. You integrate it based on the best research evidence, the patient values, and the clinical circumstance. Okay. And another thing that you need to do in your decision making is should be localized. No, there are evidences around the world, no articles coming from different countries, but eventually the decision should be localized. No, okay. So now let's go to the patient values. No, how do you elicit patient's values? Okay. Um, the average patient preference or values differ from the average physician preferences. No? If the physician values determine the decision, many patients won't get what they want. No, so right now, I mean, years back, you just if you're a doctor, you just tell the patient what to do, and that's it. No, right now, no, with the internet available, uh, more patients are informed. So you need to talk to them. You need to give them the options. Option A, option B, the risks versus the potential complications, the success rates, no, and eventually arrive at the plan. So hindi na siya kagaya ng dati. Okay. So if physicians' preferences determine decisions, then your treatment depends on your physician. No, but if consider the patient values, no, many patients won't get what they want, no. So there's differences, no. Okay, so in order to advise your patient, you can use patient decision aids like this one. Uh, like on the left side is what will happen if you don't take warfarin, and on the right side, what will happen if you take warfarin, no? So here on the left side, no, if you're not going to take warfarin, the chance of stroke over the next 2 years is 12 out of 100. Okay? So ito may 6 major and 6 minor, no? So 12 out of 100, no? The chance of severe bleeding over the next 2 years is 3 over 100. To. So maraming effects, no? Compared to taking warfarin, no? The chance of stroke over the next 2 years is 4 out of 100, no? 2 major and 2 minor, no? So yeah, you let the patient eventually choose or decide, no? And you give them the evidence, no, of taking or not taking warfarin. At least they'll be able to appreciate, no, by giving this aids. Okay. The level of diagnosis, no. So disease is a pathologic state. Illness is the effect of disease on our physical and mental health, and eventually, the predicament is the illness situated in socioeconomic setting. No? For example, stroke in the young and old patients may be the same disease and illness, but of course, the predicament is entirely different. No, it has a big effect. If you're young, you're still working, you're the breadwinner of the family compared to like you're old and retired. Okay, most of us can diagnose disease. Few of us spend time to diagnose the predicament. No, for example, we always speak of hypertension as a disease. We never speak of hypertension, the predicament of lifelong treatment, lifelong medications. No? So um, practicing requires our sensitivity and our expertise in diagnosing predicaments. So like in ophthalmology, uh, we know that glaucoma is a disease. It can cause uh, an effect to the patient. But what's the predicament, no? To the patient, no? Patient unable to drive, unable or needing assistance from a caregiver in order to move around. So that's the predicament. Okay. So evidence-based medicine is a systematic approach to the acquisition, appraisal, and application of research evidence to guide our healthcare decisions. No, uh, remember this. Okay, how do we start? The styles of EBM, bedside EBM. Okay, old, lagay ko na lahat. Okay, although a lot of doctors say that they cannot practice because they don't have the time, what they don't realize is EBM actually has the solution for their lack of time. Learning to appraise an article will cut short the amount of reading and reading time by 90%. Of course, if you have no intention of updating yourself and just sticking to what you learned in medical school, then learning EBM is just an added work. However, Would you believe that half of what you learned in medical school is wrong by the time you graduate and practice? Unfortunately, you don't know which half, no? So learning EBM will help you distinguish which is which. Okay? So here's different ways on how you practice EBM at bedside, no? For common conditions like hypertension, cataract, glaucoma, there's appraising mode, no? For less common conditions, you search, no? Searching mode for pre-appraised articles. And then for rare conditions like maybe CAs, no? There's a replicating mode for from authorities, no? So number two seem to be the most efficient and most acceptable style for most of us, no? Okay. So here are the resources, no? So sure of the evidence for number one. For number two, there's sure of evidence-based care. And for number three is you're never sure of the evidence, no? Because of the rarity of the condition. Okay. So here are some pre-appraised sources, no? Evidence-based child health, evidence-based medicine. In ophthalmology, I think there's the systematic eye review. So those are pre-appraised sources. Okay. How to cheat practicing EBM, no? So as I told you, the pre-appraised journals and textbooks, the structured abstracts, Cochrane reviews, and there's the evidence-based clinical practice guidelines. In ophthalmology, the Philippine Academy of Ophthalmology already updated the CPG on cataract. There are there is the Asia Pacific Glaucoma guidelines and the European Glaucoma Society guidelines, but sometimes no, they're not technically CPGs, no. So there's a proper way of making CPGs. Okay. So tips, no, in practicing EBM, don't be afraid to make mistakes. Don't teach. Be a co-learner. Be a role model, no. It's very difficult, not the all-knowing experts, but rather be an information-seeking person. Okay. If you are curious, then you are a role model. Okay. So in summary, EBM is essential in medical decision making. And there's a cycle. You ask, there's the question, you acquire, you search for the evidence, you appraise the evidence, and you apply the evidence to your patient. Practice of EBM need not be difficult. Okay, so I'm sorry, doctor, but I have to disagree. No, this is a cartoon of well, this is old, but right now, no, wala na siguro yung typewriter, wala na, andyan na yung computer, wala na yung newspaper, but rather, andyan na yung iPad, yung internet, yung Google. Okay. So what are the some EBM misconceptions in developing world? No? Irrelevant for traditional treatments. It's a misconception. Impossible in rural settings. It's not applicable in the midst of poverty. No? Those are misconceptions. No? So we must protect our patients with their higher degree of vulnerability from the dangers of available technology. Even if a useless treatment was absolutely harmless, given the disparities in funding pediatric care, we must avoid any waste of time, cost, and effort. We should use the evidence to choose which is the treatment or test that can be best help our patients. Okay? Poverty or limited resources is the reason to practice EBM. It's not an obstacle. Okay? So think big and but start small and act now. No? Hopefully, um, you learned something from this lecture. Thank you.